aspect. Of course, it's very minimal surgery. We don't let any drainage. And 6 months later, 5 and 5 scars are invisible, and you keep usually a small scar which remains visible at the place of the lens port placement. About complications, it's very rare. You have quasi no risk of vascular injuries. If you have a safe technique of dissection, risk of bowel injury is very rare. I think that the most important post-operative problem that you can find is the risk of bleeding in the pelvis and obstruction with the clots of the double stent. And in this kind of situation, clinical aspect is every time the same one. You have not a normal evolution of the first and second day outcomes. You keep some pains, you feel some resistance on the abdominal wall, and so you have to go back in the room, you have to remove the double G stent and to place a ureteral stent just to give the best drainage, because if you wait too long time, you risk to have a complete clotting on the pelvis and perhaps to go back in the new surgical laparoscopic approach. So if outcome it's not perfect 2 days following pyeloplasty, that means that perhaps you have a problem of drainage of double G, and it's better to go back in the room to remove and to change with the ureteral stent. About post-operative protocol, we used to remove the catheter day 2 or day 3 following surgery. Usually the patient leave hospital day 4, and we used to remove the double stent 3 weeks following. As you know at this time, concept of 1 day surgery is very fashion, and as much as possible we try to perform surgery in a 1 day hospital stay. I think perhaps pyeloplasty could be a good application. That means that you let the patient live without drainage, of course, with a Foley catheter for 2 days, that perhaps it will be possible to accept that the patient is entering the morning and leaving evening with a Foley catheter and without abdominal drainage. But we have no still this experiment. About conclusion, just to say that laparoscopic approach is a very, very nice option for pyeloplasty because of the mini-invasive character and because of quality of the surgery. It's just mandatory to perform and to master technique of laparoscopic suture. And what will be a possible evolution from traditional laparoscopy to robotic laparoscopy is to use robot because if you have access to robot, of course, all the job of the suture is very, very easier thanks to the robotic technique. And so I don't know if you have access to robot, but perhaps if you have, you can do it from laparoscopy to robot. I can stop here about pyeloplasty if you have some questions, and then we are going to move to the stone treatment approach. Yes?
Just about the follow-up, one of your slides told you practiced intravenous urography 2 months later. I suppose you don't do it anymore?
No, we perform CT scan 3 months following the removing of the virgin.
Okay.
CT scan, uroscan with injection.
And if the patient is asymptomatic, does the CT change something to your attitude or not?
No, just for us. It's to
Just
be
for
sure
you.
that we did a good job. But anyway, you have to check. So if you have just transonography controls, I like to see my, but it can be particular, I don't know, but it's just for us.